Nik Nikam. This is cardiology seminars, and on our YouTube channel we have more than 160 lectures which you can watch at your leisure. And please do also subscribe to our YouTube channel. The feature presentation for this seminar is going to be heart structure in simple terms. So let us begin with the feature presentation. As you can see here, we have the superior vena cava and the inferior vena cava draining blood into the right atrium, which is located on the right side. The right atrium is separated from the right ventricle by the right coronary artery. We'll talk about coronary arteries in a minute. And this is a right ventricular inflow tract, and this is the apex. This is a right ventricular outflow tract, this one, and it is also called the infundibulum. It ejects blood into the pulmonary artery. The main pulmonary artery divides into the left pulmonary artery and the right pulmonary artery. The pulmonary artery is actually located in front of the aorta, which becomes important when you're looking at echocardiographic images. That's one way to identify. Also, the aorta is located in front of the left atrium. That helps to identify the structures. Okay, the right ventricle and the left ventricle are separated by the left anterior descending branch, which runs along the interventricular groove. And the aortic arch forms a nice arch here. It gives rise to three branches: innominate, left common carotid, and the left subclavian. The aortic notch is an important structure, which I'm going to show you in a minute on an X-ray. And after the aortic notch, we have the pulmonary artery, and below that we have the left atrial appendage. That's the only part of the left atrium we are going to see in the anterior view when you open the chest apart. And behind that are two pulmonary veins coming from the left side, and below that we have the AV groove, which separates the left atrium and the left ventricle, and this forms the left ventricular border, which is covered by the lateral wall of the left ventricle. Let's talk about a little bit about the coronary arteries. There are two main coronary arteries, the right and the left coronary artery. The right coronary artery arises from the right coronary cusp, which is located anteriorly, and it traverses along the right atrioventricular groove. It gives rise to the sinus node branch. It also gives branches to the AV node, and it also gives the acute marginal branches which supply the right ventricular free wall. Whereas the left coronary artery arises from the left coronary sinus, and it runs behind the pulmonary artery and divides into the left anterior descending branch and the circumflex branch. The left anterior descending artery gives rise to the septal branches and the diagonal branches, whereas the circumflex gives rise to two or three marginal branches, and it joins the right coronary artery in the back. The right coronary artery also gives rise to the big posterior descending branch, which is known as the PDA commonly, and it supplies the inferior wall and also the apex of the heart. And here I am correlating the anatomic structures with what we see on the X-ray. The purpose of understanding the structure and the anatomy of the heart is to see how we can identify pathology when we look at electrocardiograms, or when we look at X-rays, MRI, CT scans, or nuclear studies. As you can see, the heart seems to be moderately enlarged in this X-ray, because the width of the heart shadow should be less than half the width of the chest cavity itself. So it's much bigger than that. And this is the right atrium. And as you can see, this is the area that is showing up here, which seems to be enlarged. And here is the superior vena cava, and here we have the trachea. And if you come here, we have the aortic notch, and below that we have the pulmonary artery segment somewhere here, and the left atrial appendage is somewhere around here. And this represents the lateral wall of the ventricle, which is formed by the lateral wall of the left ventricle, and it is sort of bulging, suggesting there may be evidence of left ventricular hypertrophy or cardiomegaly or even some degree of pericardial effusion. The inferior wall, which sits on the diaphragm, is formed by the right ventricular inferior wall. So there are a lot of things we can deduct from understanding the anatomy and structure of the heart and how they look in real situations, be it normal or pathological. Next, we'll move on to the next. We are looking at the back side of the heart here. Here we have the circumflex branch which wraps around. It gives the marginal branches before it joins the branches of the right coronary artery. And you can see the right coronary artery giving the posterior descending artery, or the PDA as it is commonly known. Then we have the coronary sinus, which is draining blood from the front and the back of the heart into the right atrium here. And right behind the aorta, as I told you, we have the left atrium, which is receiving blood from the 4 pulmonary veins, 2 on each side. And on the right side, we have the superior and the inferior vena cava, and here is the right atrium as it looks from the back side. An important point to remember is the position of the coronary sinus, and it will come in handy when we are looking at echocardiograms or CT or MRIs to identify various structures. And of course, the coronary sinus is also used in placing left ventricular leads in patients with heart failure. Let's move on to the next picture. Here we are going to focus on the pericardial sac. Pericardial sac acts like a lubricant. It has 2 layers. One layer that covers the myocardium. It is called the visceral pericardium. And then we have a parietal pericardium, which is a sort of outside the heart. And there's a liquid between these 2 layers, about 50 cc's, which acts like a cushion. As the heart is beating, it acts like a cushion so that the heart structures are not damaged. Of course, the pericardium can get disease in conditions like uremia or pericarditis, and can have a large pericardial effusion. And pericardial sac is important, but it is not essential for survival, because after heart surgery, surgeons often leave this pericardial space open. If there's a large pericardial effusion, they can open up the pericardium and leave the fluid to drain into the lungs. And here is the cross-section of the heart, showing the entire thickness of the heart muscle, which is approximately 1.1 centimeter on the left side and between 0.3 and 0.5 millimeters on the right side. The inside surface is covered by the endocardial layer of cells covering these muscles, their bands, and also the structures. And of course, the heart is a structure made up of a striated cardiac muscle, and here we have the visceral pericardium sort of forming the outer limit of the cardiac structure. And then we have the pericardial space. After that, we have the parietal serous parietal pericardium, and after that we have the fibrous tissue which covers the rest of the pericardial external surface. So that is a cross section of the heart. We are going to move next into the electrical system of the heart. The electrical system of the heart is the one that keeps the heart beating. There are certain cells in the heart which have the ability to spontaneously depolarize. That means they get activated. When they get activated, they send an electrical impulse through this electrical grid system inside the heart, and that propagates the impulse. These pacemaker cells are nothing more than specialized myoepithelial cells, and the sinus node is located at the junction of the superior vena cava and the right atrium. It gives rise to the interatrial branches, and it sends the Bachmann bundle to activate the left atrium. These interatrial fibers join the AV node, which is usually located at the crux, at the junction of the four chambers, and it gives rise to the bundle of His. The purpose of AV node is to delay the impulse. When the atria are contracting, you want to allow enough time for them to squeeze the blood into the ventricles. So that delay is built into this AV node. Then the bundle of His divides into the right bundle, which supplies the right ventricle, and the left bundle supplies the left side. The left bundle is interesting. It has three different branches. It has a very tiny branch at the beginning, which supplies the base of the ventricular septum. Then we have the anterior fascicle, which is kind of thin and small, and it's weak. And we have the stronger one, which is the left posterior fascicle. So these activate the heart. As you know, both atria contract at the same time, and so are the ventricles, which contract at the same time. Now let's talk about heart valves. We have the tricuspid valve here, which separates the right atrium from the right ventricle. It is called tricuspid because it has three leaflets. All these leaflets are made up of collagen tissue covered with endothelial cells. And then we have the mitral valve, which is like two leaflets wrapping around. The posterior is the big one, which is like almost semilunar, and then we have the anterior one, which wraps around the posterior large leaflet. Then we have the aortic, the pulmonic and the aortic valves are sort of similar. They are three semilunar leaflets in each valve, and they keep the blood from leaking backwards. So these heart valves, I did a separate video on heart sounds and heart murmurs. You can watch those. So the heart valves help to propagate the blood through one direction. It prevents the blood from backing up. That's why when patients have valve incompetency, or if the valves are stuck together, we're going to get a leak, which can lead to mitral regurgitation, aortic regurgitation, or tricuspid regurgitation, depending upon what the case may be. So this is, in summary, a very quick review of cardiac structure. I hope this has been useful to you, and please do subscribe to our YouTube channel, and we will see you next time. You can also get a copy of my cardiology rounds manual by sending me an email to drniknikam@gmail.com. You can see the name in the comments, and I will see you next time. Thank you so much for watching this presentation.